I'm gonna miss breakdancing next year or next Olympics. That was a fun event to watch.
Yeah, that was fun. Okay, good morning, everyone. It is 7 o'clock. Welcome to our pediatric webinar update. Great to see all of the names popping into the chat. So good morning, everyone. And I think for some of us in areas that we're in, this is the first day of school as well. So that's always a landmark time. Um, my name's Neil Davis. I'm a pediatrician and lucky enough to be able to be part of this webinar. Just as a reminder, for best practices, the cameras and microphones have been deactivated and muted, but we really do want people to be highly engaged in the chat. Our format today is going to be going through some slides and presentations, and we really want questions. So it just makes the conversation more lively and engaging. So please put thoughts and questions into the chat. As you can see on the bottom there, we're also recording this so it can be posted on Primary Children's YouTube channel so people can view this later if that's more convenient for them. And also we have the CME number. And Kylie, if you don't mind, just when you get a minute, doesn't have to be right now, but put the CME number in the chat for people so they're able to access that. All right, Kylie, if you can go to the next slide. And with that, I should give a big thank you to Kylie. Thank you for that. We really appreciate it. A few announcements. Just as a reminder, there are many ways to get our continuing education, and another awesome way is through the Pediatric Echo program. And there's one, as you can see, coming up next week at noon, focused on pediatric anxiety. So just a heads up about that. And then Kylie, I believe you have more info on these next couple items than I do. So if you don't mind coming off mute and just letting folks know about these two items.
Yeah, there's a great opportunity for paternal mental health training on September 12th and 13th. They wanted me to spread that word from the state. And then there is also a great opportunity for a scholarship, and they would love this to be targeted for rural areas. So I'll put that information in the chat. And then also, it's that time of year again where you get to tell us how we're doing and what you want to see more of. So I'll put the link to the pediatric provider survey. And if you could complete that, the more responses, the better. So we can, better this webinar series and get more topics that are useful to you. So thank you, Neil.
Yeah, thank you, Kylie. And just on the survey, the annual survey, it gives us feedback so we can improve our webinar. And also, it's actually required that we get a certain number of responses so we can continue. So please, if you get a chance to fill out that survey quickly, that'd be really helpful for us. Let's move to our topic. We are fortunate to have Dr. Peter Lindgren with us today. He's a pediatrician at Memorial Pediatrics in Salt Lake. And also, he's the Associate Medical Director of Newborn Care, Well Newborn Care at Intermountain, and just a wonderful colleague. Um, just a little personal story here. I first met Peter when my oldest son was less than 1 years old. He's now 25. When we came into, I think it was Memorial, I was just in medical school at the time, and he had RSV, my first son, and and it was very stressful. I'm sure Peter doesn't remember this, but as a new parent, that was pretty stressful. And so there's some interesting connection going back to talking about newborn care, because we're going to talk about RSV today. But I'll mention Peter, you did a great job then, and you do a great job now. So that's much appreciated. All right, Peter, with that introduction, if you don't mind, again, Peter's going to go through some slides here and I'll pause with questions, but we really want your questions in the chat as well. But hot topics in newborn care, over to you, Peter.
Thanks, Neil. Well, that going back 25 years, that was the start of kids care, probably. And
Yeah,
I got roped in doing that by Mark Briesacher.
yeah.
And that will be 25 years with Intermountain in October. So, and see lots of familiar names on this. But I thought it would be a good opportunity, and thanks for the invitation to come and just talk about a variety of these things. Um, so I'm going to go through the neonatal telehealth briefly, RSV prophylaxis. There's this issue going on with a blood culture bottle shortage, but it kind of relates to our EOS stuff and might be interesting for you to see some data on that. Cannabis exposure, increasing rates of syphilis, hyperbiliary, and vitamin K. So anyway, those are the topics. It's a lot, but hopefully some good little kind of pearls, tidbits, and some data from our system. Um, we see what 2/3 of all newborns in the state in our birth hospitals. You can see that we had a peak around 2008, and last year there were about 27,000 deliveries in the system. So it's a real large population of patients that we hit. And one of the kind of brilliant things that Dr. Liz O'Brien did was figure out how to get a full-time dedicated neonatologist to help. So as we all know, newborns are generally well, and then sometimes they're not. And having people who are experienced and dedicated to taking care of sick babies is really helpful. So our overlap with neonatology has been really one of the successes of our system, and the 321 baby system has been in place since September of 2022. And again, improving access, avoiding transfers, streamlining transports when they happen, and basically trying to give providers a good quality experience. So just want to shout out that, and it's been a huge thing, and I think it's been really helpful for a lot of us in dealing with problems as they come up. So on to RSV, not a virus that I think anybody is unfamiliar with. Might call your attention to the fusion protein on this, but I did want to bring this to kind of a, why we're doing these things. So this is a little boy who was born term. He had some issues in his newborn care. He had pulmonary hypertension, and he was discharged home from the NICU after being cared for, but was not felt to meet criteria for getting Synagis. And within a few days of being discharged home, I saw him in clinic, did an RSV on him, and it was positive. And long story short, he ended up on ECMO. He was very, very sick. And you can see from the pictures, he's actually doing really quite well. And just another side note on this, his father was a medical student at the time and is now doing a surgery residency in Arizona and planning to do ped surgery eventually, mostly related to the experiences that he had with his son. But RSV can be a bad deal. About 2/3 of babies get RSV in their first year of life, not any surprise to any of us. And about everybody by age 2 has had it. It's worse in preterm infants. And 2 to 3% of all newborns will be hospitalized for RSV. So what are the prevention strategies? In the past, we had Synagis, but there are two strategies now. There's this long-acting pre-fusion monoclonal antibody, which is nirsevimab, or the brand name Beyfortus. AstraZeneca, Sanofi make this. And then there's also the maternal immunization, which is the pre-F fusion vaccine, which is Abrivzo, which is what Pfizer makes. So large opportunity for making a difference. Nearly 500,000 infants each year receive medical attention for RSV. and again, I realize this is probably a review for everybody, but just to kind of like hit this again, passive immunization. This is one of those things that sometimes it's referred to as a vaccine, but it is a monoclonal antibody. There are three indications for this. Basically, any infant that's born October through March during their first RSV season is able to get it. And then infants less than 8 months who are born April through September entering their first RSV season get it. Dosing, again, 50 milligrams for less than 5 kilos, 100 milligrams for greater than 5 kilos. And then if you are between 8 and 19 months and have a risk category, as defined by the AAP, in your second RSV season, you get a 200 milligram dose. There is the maternal vaccine. It is a single dose given between 32 and 36 weeks. Again, you get passive immunity through transplacental transfer of the antibodies, and this was also approved last August. So you might ask, how effective was nirsevimab in the 2023-2024 season? So this is the MMWR report, and it basically gave the kind of early estimates for effectiveness. It was a multi-site study. There were nearly 700 infants that were hospitalized for acute respiratory infections during the first RSV season, 90% effective against RSV-associated hospitalization. I must admit, reading through this, I don't get the statistics on this. But anyway, the CDC says 90% effective. I'm not sure how you entirely do that, but that's the rate. But it does support the recommendations for, again, doing prevention. There's no head-to-head nirsevimab versus Abrivzo. So we don't have any ability to say, and the CDC still is agnostic about nirsevimab versus Abrivzo. Though as a system, I think we're thinking that the nirsevimab strategy is probably the way to go for a variety of reasons, including that it lasts probably a bit longer. I wanted to share, this is the 30-day unplanned readmission rates. And you can see going back to 2019, we have had spikes in the winter, so January, February. And this obviously went away in 2020 with COVID. In 2021, we had that really early RSV year where we were seeing RSV in October. And in 2022, we had a really severe RSV year. And if you recall, there were hospitals across the country that were packed, as was primary, and there were lots of problems and issues. So go to 2023, there's not much of a spike. And again, this isn't, I mean, I can't say that this is, directly related to giving nirsevimab, but it's encouraging. And it's an interesting kind of look at our own data in terms of 30-day unplanned readmissions in newborns. So this is a little lovely slide from the CDC, and they encourage clinicians to talk to parents about nirsevimab, a preventive antibody. And again, you can quote 90% effective for protecting against RSV-associated hospitalizations. This is a nice little schematic of when to do this. So on October 1st, we will turn on the nirsevimab ordering, and that can start then. Interestingly, if a pregnant mother decided it was between 32 and 36 weeks in September, and they decided to do Abrivzo, they could start doing that then. And then babies that are born between April 1st and September 30th would be eligible for getting nirsevimab starting in October.
Peter, there's a great comment in the chat here from Jen Meyer. Maybe worth having some flyers up in clinic to get parents informed. I think, as I see it, so you're saying the hospital is going to start on October 1st for all babies. Is that right?
Yes.
That are born?
Yes,
in the
but
hospital?
I think the other thing, Neil, would be that clinics certainly could as well.
Yeah. Yeah, go
Uh,
ahead.
yeah, so our strategy for this coming year, there are a couple of important things, and this is kind of from some communication with Tamara Sheffield and pharmacy. There's not anticipated to be any supply concerns for nirsevimab this year. We already have supply from last year on hand, and so we anticipate being able to kind of flip the switch and start doing this on October 1st. If you recall last year, one of the issues in the newborn hospitalization is that newborns are paid on a DRG code, which didn't cover the cost of nirsevimab. And that issue was resolved in January. We started doing it in all well newborns kind of mid-January. And so it should be able to be given to all babies born in hospitals. One of the things that Dr. Sheffield also shared was some data from the Utah Department of Health looking at when people actually have visits after hospitalizations. And surprisingly, not everybody has newborn follow-up in the first month. And so the strategy of giving it to babies in the hospital, I think, should be really stressed. Um, and that's probably even more true in the Medicaid population. So there are educational sheets basically detailing the nirsevimab and Abrivso. But our anticipation is that our ability to do the nirsevimab will lead to a decreased use of the maternal vaccine. And then there's some CDC estimates just for, babies that got it last year. So about 50% of infants were protected last season, most of which were with nirsevimab.
Yeah. Great question from Tim Larson. Is there an effort within Intermountain or Primary Children's or frankly the Department of Health to coordinate marketing to educate the public via social media and other avenues about nirsevimab?
Yeah, you may know better than I do, Neil, what the kind of
Yeah,
thing is, but I do think it's something that we should probably begin having some of
yeah,
those conversations, and particularly in clinic. And I think, knowing that we're basically a month and a half out from that. But even in well child checks, having conversations with families who have babies that were born April through September, I think, priming them to do that. Um,
yeah. Yeah, it's a great question. I have been in contact a little bit with the team, the media team at Primary Children's, and I think that that's something we can dig into more as well. Now, my understanding, Peter, is that I think Intermountain hospitals are the only hospitals in the state that are giving nirsevimab as part of the newborn stay, and I would love to be corrected if I'm wrong on that. But that puts a, a responsibility on us as pediatric clinics to get these kids in. If they didn't get it in the hospital, they didn't get a chance to in the hospital, or they were born in that window, we've got to we got to get those kids in.
yeah, and I would be curious for many of the affiliated docs who are on whether it was done last year or whether there's anticipation to do it this year, at any of the other birth hospitals. Um,
Yeah. Yeah, I don't know that it is. Now, one thing that I do believe is that the use is forecast, as we all see now. We see that RSV is listed down there, and so it's going to be tracked there. Yeah, so I appreciate this in the chat. So Cynthia Owens saying St. Mark's is not going to be giving it to well babies, given in the NICU. I think that's probably the route that most other systems are going to go. So I think it's going to be really important for us to be aware of that, and also likely to have concerted effort to get the kids in that were born in the spring and summer in October, get them in October, November if we can, to help protect those kids.
yeah. Thanks. There was also a question in the chat about whether high-risk babies. So yes, high-risk babies between 8 and 19 months would get it during the second season. Um,
Wow, and some good information from uh, Dr. Martin Garg there as well related to Logan. I'm assuming that's Logan Regional Hospital, the Intermountain Hospital there. But yes, if there are other systems that are giving it, that would be good to know. But to my knowledge, the only health system that's giving nirsevimab in the hospital um, is Intermountain. So just important to be aware so we can get as many babies in as we can.
So yeah, so there are some staff sheets, and again, this will get flipped on, but just want people to be kind of aware of it and thinking about it. Any other issues or questions
Mm.
on the nirsevimab? And
Yep. One more question. There's a good question. Some parents are always scared about vaccines, especially for younger babies. Do you have any talking points to reassure parents?
um, yeah, I guess I'm scared about RSV. I mean, I guess there's always that balancing of you know what you're what you're preventing against, and I think the idea that 2 to 3% of all newborns are hospitalized for RSV in their first year of life is pretty amazing. Um, and while mortality is really low, like some of those kids are really, really sick. Um, I don't, I mean, I guess I'd really like to be able to give you a bunch of safety data off the top of my head about nirsevimab, but I can't off the top of my head. But I'm sure that like there's really good safety data, and we have very good efficacy data that it's helpful. So a 90% protection against hospitalization.
Yeah, great thoughts. I remember seeing the New England Journal of Medicine article where there weren't increased, rates of adverse reactions in the group that got nirsevimab versus the other group. So I think that's important to know. But I think people still are appropriately afraid of RSV, and at least that was my experience last year.
Yeah. We can come back, but there's been an interesting issue about blood culture bottle shortage, and people have said, why is there a blood culture bottle shortage? And this was from Bert Lepansery from the movie The Graduate. One word: plastics. So the manufacturer, Becton Dickinson, has had some issues allocating supply, and there are some issues with having adequate supplies of blood culture bottles. Intermountain Health has a reasonable inventory, but it's not know how long the shortage will last. And we were asked to review our policies and practices on blood culture uh, optimization. So you guys are probably all aware that in June of 2021, we instituted this new EOS risk categories to basically direct both surveillance and management of newborns who had risk for early onset sepsis. And this really directed clinical care and made recommendations and did it with frequency of vital signs and when to collect blood cultures and get empiric antibiotics. So there are a variety of categories. If you have an EOS risk less than 1, and were well appearing or equivocal, the recommendation was to not get a blood culture and not start antibiotics. The risk categories where you're 1 to 3, it was to get blood culture bottles. And if you had an EOS risk of greater than 3, it was not only to get blood culture bottles, but to start empiric antibiotics. So I just threw this one in to kind of remind people of what defined equivocal and clinical illness. But I think people are generally pretty familiar with these by now. And this may be a little bit hard to see, but I want to call out a few things. So this is actually the data from the last 3 years, but I'll call your attention to the top. When you look at this category, so babies that have an EOS risk less than 1 or the EOS risk decrease less than 1, babies were well appearing or equivocal. In that group, there were about 71,000 babies, and there were no cases of early onset sepsis. What's interesting is that in that group, there are still babies getting blood cultures. In fact, 2.9% of babies were still getting blood cultures. Now, I'm not certain why that is entirely. I suspect some of it has to do with maternal GBS status. It may have to do with whether or not somebody has had an IV for hypoglycemia and they just get a blood culture because they're putting an IV in. Not entirely clear, but it would basically save us about 57 blood cultures a month through the system, and it would miss no cases of early onset sepsis. So the ask is that if you have an EOS risk, well, basically the ask is follow the guideline. So the other category that we looked at was this one, the question of could you eliminate doing blood cultures in this group of about 1,000 patients who had EOS risk between 1 and 3 who had a well or equivocal exam. And there was one case in that group, which kind of fits with the 1 to 1,000, 1 in 1,000 risk. So our recommendation really was that we should probably continue to do what we're doing, but to not get blood cultures in that EOS less than 1 group. So follow the recommendations, please. But pretty cool, right? I mean, 71,000 patients, didn't miss anybody, works well, and I think gives us some reassurance that that's good data that you can kind of fall back on.
Yeah, that's reassuring to me. I know any change where it relates to something as worrisome as sepsis in a newborn is something that, raises the blood pressure a little bit for me. And so being able to see that's valuable.
It's I mean, these are sort of, basically these betting risks, right? When you bet, how do you hedge? I mean, a blood culture is definitely a hedge. Observation, increasing vital signs is sort of that hedge. But
yeah, great news.
Yep. A little update on hyperbiliary. So here are our phototherapy rates for the last 4 years. And you can see that, it fluctuates and stuff, but the AAP's recommendations came out in basically September, October of 2022. We did a bunch of educational stuff, and you all adopted doing the new AAP guidelines, and you can see a rather dramatic drop in the rate of phototherapy in the system. And that's continued, and it's been done without any kind of EHR support, which is coming with Epic. But anyway, this is sort of a thank you for just being good docs. And I think, Neil, you spoke about kind of how, implementation takes a long time.
Yeah.
And this is extraordinary.
Yeah.
And it didn't take a long time. And, pediatricians are really good. And here's a little cost savings data. So Eric Henry put this together. In 2022, there are about 1,600 babies that received phototherapy. In 2023, there are 927. So there was a cost difference in those cases of about $3,000. And so when you take the cost differential, it was about a $2.1 million savings in the system. So that was rather striking, and I think just something to it's a win. And I think something to be celebrated. So, and again, thanks to everybody who's followed those, and hopefully we will have. Epic has built into it a system, though we've decided to engage with the University of Utah in using their Billy app, which a variety of people on that side developed, and it's very slick. It'll be very nice, and it will make it so you don't have to jump around to other sites and enter data. So it's coming.
So Peter, really quick, just a nice, there's been a great discussion in the chat between Miguel Knokel and Tim Duffy related to the nirsevimab. So I just call people's attention to that. And then the other is just a call out for the pdtools.org, as well as you have the tool here. But quick question, did we have, as people adopted the guidelines, you may have mentioned this and I might have missed it, did we have an increase in readmissions for hyperbilirubinemia? Oh,
Thanks, Neil. That's the next
okay.
slide. So you can see the trend for readmissions has decreased, which probably shouldn't surprise anybody because the thresholds went up. But that question of like, are we missing things and are we having increased cases? So readmission rates, the trends are decreased. But I would also point out that, so this is just to kind of give everybody a baseline. So the dark blue line is Billy's over 20, and the red line is Billy's over 25. And you can see we, in 2023, didn't have any. There, I think we've had one Billy over 25 that I just looked at recently, and it was a baby that honestly, didn't have, elevated risk, but I think did have a cephalohematoma and came back appropriately, and their pediatrician checked and the Billy was up, was treated, went down, didn't seem to be a hemolytic issue. So, so this is being done, we think, safely, without an increased signal towards higher rates, and we don't think we're missing biliary encephalopathy.
All right.
Okay, excellent. So kind of a theme here that I'm catching from the past two topics is when we have good evidence-based guidelines and recommendations that have been essentially well vetted and put out there, when we follow them, we're doing well, and we are following them for the most part, which it seems like.
Yeah, well, I think, I mean, it seems like we have better ability to kind of like get some of that data and look at it. And it's an exciting time to be able to make some of these things and not have to treat based on anecdote or.
Yeah, very good. I wonder, it looks like we might have one person not unmute. I think I can take care of that. A nice shout out in the chat here for you, Peter, and for Dr. Liz O'Brien, helping to lead these kind of efforts. And I know there are great leaders in other systems as well that have been impactful on this. I feel like our community of pediatricians here across the state have been really, really good at adopting guidelines. And I, again, appreciate your leadership. I think that's a good call out.
Well, thanks. And I think, one of the things, I mean, here we all are at a 7 a.m. talk to kind of review some of these things and think about stuff. And I think, just we have a lot of really good engaged people. And I feel like, even in our kind of leadership roles, like we're still all playing. And, and I do feel like, the mission around this has been very clear, right? So, and Neil, I really appreciate this series and being able to kind of, see things and have things come up, but also have an avenue to be able to connect around this. So it's been really good. This is a terrible picture. I'm sure photoshopped, but one of the things that has kind of like been a difficult thing to kind of think about and talk about is what we do with what we know is an increasing uh, substance use issue. But in May, there was a report out that cannabis tops alcohol as Americans' top daily drug of choice. So in people who are using something on a daily basis, that is, cannabis is outpacing alcohol. Certainly, there's still much more alcohol use in the US, but it has gone up. And there's a lot of epidemiologic data in use of marijuana in pregnancy and breastfeeding. And we're in a very unique position to be able to talk to people about these things and to give information. And I think, we're often sought out as knowledgeable subjects on this. And my feeling has been that I have not been a very knowledgeable information provider about marijuana. And so it was one of those things that I wanted to look at. And there's some pretty good stuff written. The legalization, obviously, I think gives people a false sense of safety. There is an increased prevalence reported during pregnancy. And there's one study that showed 15 to 18% of urban, young, socioeconomically disadvantaged pregnant women were using marijuana. So like almost a third in some cases. So it's a lot. There's the PRAMS data. So this was some data from 2013 in Vermont. Almost half of women who reported using marijuana smoke before pregnancy continued using during pregnancy. So that's pretty depressing. But there was also another study that actually, when counseled, there's a study of 100 women about they're using marijuana at the beginning of pregnancy who received substance abuse counseling, and 78% were abstinent 151 days later, remained abstinent until delivery. So again, the case and the plea is that people are good at taking that information and making good decisions about it if they have it. So oops. Sorry, I flipped thread. So we have cannabinoid receptors. There are two types, and there's this endocannabinoid system, and that shows up in the developing fetus around 5 weeks gestation. So it's around an early embryologic development, but it plays an essential role in neuronal development and cell survival. And it also provides controls over cell proliferation, migration, and differentiation. So early exposure, particularly during embryogenesis, has some fairly significant effects, and there are some long-term data to support that. So it can result in long-term neurobehavioral consequences. So there are effects in pregnancy. So there are effects on the placenta, which are sort of interesting. You get impaired steroidogenesis, you get impaired development of the placenta, and impaired transport. And you actually increase things like carbon monoxide transfer as well. So if people are smoking, like there are other things that may cross the placenta more likely with exposure to cannabinoids. Babies have been shown to have lower birth weights, small gestation weights, decreased APGAR scores, more frequent NICU admissions. There are some withdrawal-like syndromes, but you get decreased brain matter, gray matter, and then there are all these kind of neurocognitive effects. And it's not a benign substance in pregnancy. So this was from the adolescent brain cognitive development study. So this is a study that was looking at long-term effects with cannabis exposure in utero. So it was a study, in this group, it's about 11,000 children, 655, so 5.5% had cannabis exposure prenatally. Cannabis exposure before was 413, and there were 242 who had cannabis exposure after maternal knowledge of pregnancy, so mothers who continued to use it. So there was an association with more psychopathology, so more of these psychotic-like events, internal, externalizing symptoms, attention, thought and social problems, sleep issues, decreased body mass index, as well as, again, mentioning the decreased gray matter volume. Not great to have that. So, and this, even looked at kind of the potential covariates, and those things still kind of borne out. And this is a little bit tricky to see. I realize it's kind of small, but it goes through all of these things. So psychotic-like experiences increase, and these are long-term studies in children. Attention problems, thought problems, but cognition definitely goes down. Birth weight was a little bit lower, but lots of social problems. So the upshot, of course, is that it's not great. There are these issues that come up now with, what do you do with a mom who's using marijuana during breastfeeding? And I think we can all agree that breastfeeding is the ideal feeding method for babies. So there's kind of this, trade-off of like, are there benefits of breastfeeding, and is that kind of better? And, again, I mean, we do that with lots of, different substances. But it's tricky because with marijuana, there's not a lot of like data on what happens in breastfeeding, and even how much of the THC ends up in milk. That said, the pharmacokinetics of THC, highly protein bound, very lipid soluble, low molecular weight, it does transfer into milk. The question about how much is transferred is tricky. And then the other thing to just kind of point out is that THC potency has been increasing. So in 1983, there were some studies that showed that the THC potency in marijuana was like 3.2%. Some data from 2008, 13.2%. But the way people are using THC now is different. And people do all kinds of different things like dabbing and vaping. And the THC content can be very, very, very high. So, again, not a benign substance. And, certainly in embryogenesis, like that whole thing is going to be probably more greatly affected. But, we're all pediatricians. We look at growth curves. You see how much the head grows in the first 4 months. To think that the brain's not developing and that there's not going to be an effect from THC, I think is a mistake. So again, I just, it's a cautionary thing, and I would just encourage people to learn a bit more about this and have conversations. And I think the hopeful thing is that people, when presented with good information, make good decisions.
There's been some great comments in the chat here as well. Dr. Liz O'Brien puts that THC can be up to 8 times concentrated in breast milk as well. This is information I wasn't as aware of, so I really appreciate you getting some facts here. That helps me a lot. So I appreciate that. I duly noted that the receptors are active at 5 weeks of embryogenesis. That's really interesting too, and some great take home here, Peter. I appreciate that.
And I think Miguel's pointing out that there's the hyperemesis. Interestingly, I think a lot of women in pregnancy may kind of be led to cannabis as a treatment for hyperemesis gravidum. And like in fact, there's no kind of efficacy data for marijuana for that. And it may actually be worse. And it is interesting that there is a hyperemesis syndrome with cannabis in general. So while it may have some kind of benefits at times for nausea, um, it also causes vomiting. Um,
Hmm. Yeah, great points. Thank you, Miguel, for that. Miguel asked another question there, Peter. If a mom has a plan of quitting cannabis, then pump/discard, how long until the milk's okay?
um,
Is that going to be a follow-up one to
I
check
think that's a
on?
follow-up one.
Oh,
Yeah,
that,
it says it
li-
can be
li-
for up to 80 days.
yeah, oof, that's a tough one. Okay, well, it would be good to find, I don't know if any one of our super smart people in the chat can look at guidelines and see if there's something clear, because I'm sure it can be present up to 80 days, but it's probably diminishing at some point in time. Benefits of breast milk would probably outweigh that, but I don't know a particular day. So I don't know if someone in the chat can discover that for us. If not, that's a follow-up item we can take. But again, great information here, Peter.
The policy within our hospitals has been that if a mother is actively using uh, cannabis, that we don't we won't feed the baby their milk, but they can. I mean, that's the
Uh, I
thing.
see.
So I think and generally the principle would be that like we're not going to do something that knowingly has some potential for harm.
Yeah.
So, and it's been a tricky issue, and health systems across the country have been dealing with this one, and it's going to be something that's going to continue to come up. So, the AAP did have a really excellent clinical report. So, and maybe Neil, I can send that to
Okay.
you PDF because it's really got some great references and great links. And as usual, they write great things, and they exist, and you kind of like stumble across it and go, "Oh, well, that was really amazing." So,
Okay. Great. That'd be awesome.
all right, now for the next fun topic. um, I'm not going to say I'm an expert on syphilis at all. In fact, maybe that's the point of presenting this. I think most of us are not. But you should be aware that the rates of syphilis in the US are increasing. Um, going up rather dramatically. If you can take a look at this, Utah's got relatively low rates, particularly compared to some of the states around us. Um, these are in like per 1,000 births. So Utah 46.5, Arizona 421, New Mexico 521, Nevada 348. So like there are states, but we like everybody else, with the exception of Wyoming and Maine, are going up. So there are increasing rates of this. So I think the thing that happens for many of us is you walk into the hospital in the morning and lo and behold, you get a mom who has a positive RPR, and it's what to do with it. And in short, I just want to tell you, like, there is an algorithm for this. It's kind of complicated. And the request is consult Peds ID. They'll help. And it's tricky to kind of like figure out, based on both infant and maternal criteria. So I'm not going to go through this in any detail at all. Really, this is just a kind of like point of awareness to say this is available. It's in the Women and Newborns documents. You can get to that um, through the links in the reference links. But the call out is to basically say that when you're in that circumstance, consult ID.
That's a great take home.
So pretty simple.
This is Emily Thoreau with Peds ID. I just want to say thanks, Peter. These are really complicated scenarios, and you got to really get a lot of the maternal data before you can really make decisions about the baby. And so we really call on our health department colleagues and the maternal medical records and all of these things. And so it's a joint problem. And so we all have to get the right data before we know what to do with these babies. And ultimately, we really kind of are conservative, and a lot of babies get penicillin that maybe don't actually need it, but the downsides are, you know, bad. So we're gonna treat them.
Yeah.
So
Emily, I think
anyway,
there's a grand rounds coming up on
yeah,
syphilis in a
there
few
is.
weeks. So just another one of those things. I think probably would behoove all of us to lean in a little bit on this, because it's something that we're gonna come across, and having worked through a couple of these, they can be confusing.
They're even confusing for us. And so, we have to follow the algorithms. And most of the time it's because you don't have the data that you need, or the moms only have partial data, or they've come from another country and you don't have their data, or all of these things. And so that's why we just say call, because we all really have to do team decision making and risk assessment for these babies. And we also follow them up, so which is nice.
Well, and it's also nice to have a pediatric infectious disease expert on this call, Emily, to jump on and give us some thoughts. So much appreciated. Thank you.
No worries, Neil.
Yeah. Oh, and Miguel put the grand rounds right in the chat for everybody, September 26th. It's awesome.
It is awesome. Good to make those things. Mark Valentine asked, where are the women and newborn documents now? So as you're all probably aware, there's been sorry, I'm gonna mess this up for a little bit, but I anticipated that somebody would ask this. So can you guys see this test
Yes.
case? So in the neonate workflow, so if you're in the well newborn, or even if you're in the NICU workflow, in the components section, you have this reference links, okay? So within iCentra, we've listed a bunch of the fairly common ones, so you could click on those to get there. But if you just click on the top line, the Women and Newborns Clinical Guidelines and CPMs, it will take you to this, okay? So if you were to type in syphilis, you would get that algorithm. So trying to decrease the kind of work to get to those things, and it has been a point of frustration for all of us that getting to the right documents is difficult, and where do they live? So just again, to sort of call this out, when you're in the well newborn workflow, the neonate workflow, you do have that as a component, and it will take you to those things. It also has links to Billy Tool. It has links to some of the more common things. So you can get to the Women and Newborns Clinical Guidelines through the SharePoint stuff, but it's tricky. It requires a bunch of links, and it seems like it's perpetually changing, which is a frustration. But these are still, these links are still good, and they'll still get you there. And I hope that's helpful. Mark, did that answer it? But I don't know that everybody knows that those are there.
Yeah.
So just a kind of call out.
Yeah, I didn't know that, so that's good.
All right. Well, there you go. It's hopefully one of those things. All right. Our last, I think we're going to have gotten to each of the things.
Yeah.
So this is a problem. I think in the post-COVID era, we have had more skepticism and more. I think they're worried. I think they want to have control, and I think one of the ways of having control is sometimes refusing things. So this is a little bar chart of the amount of time, the percentage of patients that are refusing erythromycin, ophthalmic prophylaxis, and vitamin K. So you can see in 2018, across the system, it was a 1.1% refusal for vitamin K. Go to 2024, we're at 4.5%. Like, that's crazy. And it's like kind of steadily kind of grown, in that sort of post-COVID range. And again, it's alarming if you kind of do the estimates, and again, a little bit tricky, but the rates are usually like estimated to be 25 to 170 cases per 10,000 births for vitamin K deficiency bleeding if you don't give vitamin K. So just some kind of like numbers from 2022, 26,000 births at a 3.5% refusal rate. That was almost 1,000 babies. So you'd expect to see somewhere between 2 and 16 babies with vitamin K deficiency bleeding. And this was one, there are two different pictures, and these are not from the same patient, by the way, but there is a patient who had an intraventricular hemorrhage and spent a couple weeks primary and had a very expensive hospital stay. And the one on the right is a picture from Eric Jorday, who took care of a baby with vitamin K deficiency bleeding who had a GI bleed. So definitely something to kind of think about, and again, continue to engage people on. And, like hopefully having some things, to kind of say like, yeah, this is not a great thing to have. We should focus in on this group. And I would love, 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 love if, like we could come back in 2025 and show that there's a decreasing kind of rate of this. I will say that in just, my own little narrow kind of window of the world, I had a patient that I saw last week, family I didn't know quite well. It was their fourth kid, and they had refused, and they were born at Riverton, and the pediatrician at Riverton talked to them and they consented. And so I think, people I think do make reasonable decisions, but for whatever reason, there is a kind of significant bump. And I can show you data on kind of where this is happening. It's happening more in certain places, which, would suggest that there are certain cultural factors going on that are influencing people's decision making. But I think we just need to continue to have good, thoughtful conversations with people about this.
It seems to be a skill for community pediatricians now, this idea of really respecting where people are at and being able to use those motivational interviewing skills and nudge and support people to better information. It's challenging.
Yeah, Miguel, I agree. I don't think you want to motivate people by fear. I think you want to have them motivated by knowledge. But I think, this is like a really old topic. I mean, hemorrhagic disease of the newborn was kind of figured out, like in the late 1800s. And in the 1940s, we figured out that giving vitamin K eliminated this. So I think the idea that a really simple thing like giving a vitamin at birth, which, doesn't seem like a really big deal, does prevent some kind of scary things. And it doesn't always happen. So I think the other part is, people have confirmation bias. They don't give vitamin K and they're like, well, we didn't have a problem. And you're like, well, great. But, you also got in a car and drove and didn't have a problem, but you still put your seatbelt on because, you might get hit. So I just, I think I'd like to go back to like less than 1% of people refusing.
We've got about 1 minute, Peter. A couple of things to call out in the chat. Jen Meyer put a great link there so people can go, a resource she's used to counsel parents. Can you comment on oral vitamin K just in the last minute here for people? Because more people are asking about that and sort of opting for that. Can you comment on that?
Yeah. So I think the kind of the tilt should still be towards IM dosing. Oral vitamin K has been shown to decrease the classic form of vitamin K deficiency bleeding, which is in the first 2 weeks. So that's great. but it doesn't prevent late onset unless you continue to give it. There is not a easily obtained oral form of this. If you were to go to that reference links, you would actually see how to order vitamin K in the hospital if somebody wanted to do that. So that would be better than nothing for certain. So again, in that reference link, you can go to the vitamin K information for providers, and it will actually give you kind of the instructions on how to order this. But know that people who are making decisions about doing oral vitamin K may be doing some things outside of the hospital, and there's really, there's no oral formulation that's licensed. I think you can get pharmacists to compound it, but it only like stays in solution for a short amount of time, and you have to continue to do it. And there are lots of studies in some of the European countries that basically show that adherence to those strategies with oral vitamin K are low, and you can have vitamin K deficiency bleeding out to 6 months. So again, such a simple, elegant solution to do an IM dose, but it's not a terrible alternative. Certainly better than nothing. But
Okay.
hopefully that helps a little bit.
No, that was awesome. Great conversation today. We are at time. Kylie put the CME code again in the chat. I'm going to mention that for those who might be listening, 34604 is the CME code. Peter, thank you for your time, your expertise, and your thoughtful leadership. We really appreciate it. And thank you to those in the chat for the great conversation and links and good discussion. And hope everyone has a wonderful Wednesday. Thanks, Peter.
Thanks, Neil.